Hi, everyone. I'm really excited to welcome you all to the Bureaucracy and Service Delivery panel. My name is Zahra Mansoor. I'm a postdoc at the Blavatsky School of Government, and I'm going to be chairing this panel today. So without further ado, I would now like to invite Michell, who's going to talk to us about the unintended consequences of vertical health programs. Michell, please, can you put up your presentation?
Hello, everyone. Thank you for this opportunity to present my research at this conference. I'm happy to present a chapter of my PhD dissertation, which is also a side project from a research conducted with Pedro Canedo from University College London, Marcus Holman from the World Bank, and Edith Bellamy from the World Bank. So to provide some motivations behind this project, behind this study, development aid programs can result in spillover effects or general equilibrium effects, which can weaken or strengthen the effectiveness of these programs. For instance, following a cash transfer program in the Philippines, there was an increase in food prices, which led to worse health outcomes for non-beneficiary children. Also, in the Dominican Republic, following a public school construction program, competing private schools were crowded out from the market. In the public health field, health interventions may also generate unexpected spillover effects on health outcomes not targeted by the program. To understand why this is important, one widely known example relating to our current situation is that COVID-related policies led to a decline in non-COVID healthcare utilization, including cancer therapy and cancer screening. At the same time, it is difficult to empirically test these spillover effects since most programs only monitor health outcomes directly related to the project. I tried to overcome this challenge by exploiting a randomized control trial that took place in southern Nigeria. This paper also aims to contribute to the debate on vertical versus horizontal approaches to health service delivery by showing that vertical health programs that target a selective number of health issues can result in unexpected spillover effects. So the research question that I'm trying to answer is, does an intervention that trains and involves community health workers in treating malaria result in unintended health consequences? And if so, what is the mechanism? So why community health workers? Community health workers are a central part of the health system in many developing countries, and approximately 5 million community health workers are functioning in developing countries. They are usually members of the community that offer health services, including counseling and home visits, especially for underserved households. At the same time, many of them have not received any formal medical education, which can mean controversial quality of health services. Under the malaria control program that I'm evaluating, community health workers were involved in diagnosing and treating malaria. So why do I think this malaria control program could possibly result in any unexpected spillover effects? So before the intervention, households either seek care from formal hospitals, including public and private hospitals, and informal health providers, including community health workers and medicine vendors. These community health workers usually serve households with pregnant women or households with children under 5. After the intervention, and as community health workers provide free malaria drugs for community members with malaria, there could be largely 2 levels of health behavioral change. First, at the household levels, households that used to seek care from hospitals could alter their care-seeking behaviors and seek care from community health workers. Second, at the community level, community health workers that used to provide a variety of health services could direct their resources and efforts toward malaria-related services. So the main findings from this paper are as follows. First, we find a change in care-seeking behavior, especially non-poor households are more likely to seek care from informal health providers following the intervention. This finding is in line with previous literature that shows that more educated households are more likely to process and adopt the new information. Second, while the project resulted in lower malaria prevalence for treated households, there is an increase in malnutrition, especially for poor households. I tried to understand the potential mechanisms and find suggestive evidence that poor households are likely to be crowded out as due to an increase in service utilization by other households. I rule out the other potential channels. So this is the outline of my presentation. Begin with the context. Nigeria is the most populous country in Africa. At the same time, the Human Capital Index in Nigeria is very low, ranking 161 out of 189 countries in 2019. Also, child health is very poor, having infant mortality rate of 82 per 1,000 live births. Also, 37% of Nigerian children under 5 are stunted. Our study takes place in Anambra State, a southern state in Nigeria. The state has 327 wards, of which 280 were included in the study area for the impact evaluation. The 280 wards were randomly assigned into 4 study arms, and I'll be explaining these study arms in my next slide. So under the intervention, there were largely 2 informal health providers that were trained. First, community-directed distributors, or CDDs, whose main roles are similar to those of community health workers, and patent medicine vendors, or PMVs, that are private entrepreneurs running service outlets and selling medicines. Both of the health providers were trained related to malaria, and malaria drugs were provided for free for CDDs and were subsidized for PMVs. For this study, I focus on the impact of CDDs. Moving on to the data section, baseline data was collected in 2013 and endline data was collected in 2015. The research team collected data from both the supply and demand side actors, including household, community, PMVs, CDDs, and primary health facility workers. The total sample consists of approximately 4,200 households per wave, and we also conducted biomedical tests and collected anthropometric measurements for children under 5. The empirical strategy is quite straightforward since we're exploiting a randomized control trial. I include a dummy variable for each treatment arm. I also control for household variables measured at baseline. And I also include senatorial district fixed effect as the randomization was stratified at this level. Also, the standard errors are clustered at ward level. Before moving on to the results section, there are largely 2 main outcomes of interest, first stunting and second underweight. To introduce the definition of these 2 variables, a child is referred to as stunted if his or her height for age z-score is below -2 standard deviations from the median of the reference population. Also, being stunted signals that a child failed to receive adequate nutrition or suffered from recurrent infections over a long period of time, especially during their first year of life. A child is referred to as underweight if his or her weight for age z-score is below -2 standard deviations from the median of the reference population. It signals that a child failed to receive adequate nutrition in the period immediately before the survey. So I'll be presenting my results. The first finding is that following the intervention, households are more likely to seek care from informal health providers, including CDDs and PMVs. At the same time, there is a negative impact on child's physical growth. Height for age z-score lower by 3.36 standard deviation and a 9 percentage point increase in stunting. To provide some further evidence that why I think this negative spillover effects is indeed driven by the malaria control program, I divide the sample by age group. As you can see from this figure, there's little difference in stunting prevalence for the age group 3 to 5 years old. At the same time, we see higher stunting prevalence for children in CDD areas for children under 3 years of age. So why is stunting rate substantially higher only among children under 3 years old? As I explained earlier when I defined the stunting, child growth is particularly sensitive to health conditions during their first year of life, and the intervention was implemented for 2 years, which means that children under 3 years of age were the group exposed to the program during their first year of life. I'll be moving on to the heterogeneity analysis section. So, as explained earlier, how more educated or more richer households are more likely to process and adopt new information. So I expect there will be a heterogeneity treatment effects by household wealth, which is proxied by asset index. As you can see from this table, I find that only non-poor households are more likely to seek care from informal health providers, meaning that they're more likely to benefit from the intervention. At the same time, only poor households living in CDD areas are more likely to be stunted. So there is a heterogeneous impact by asset index. So to understand the potential mechanism,
Michelle, just wanted to jump in to say that you have 5 minutes.
Oh, sure, thank you. I created this diagram. So largely there could be 3 different levels through which this change could have happened. First, at the household level, there could be we see a change in health-seeking behavior. Namely, households are more likely to seek care from informal instead of formal health providers. Could these shift from formal to informal health providers lead to any changes? Second, we find an increase in awareness related to malaria, which can result in intra-household research transfer. At the community level, CDDs may direct resources away from general health-related counselings toward malaria-related services. Also, they will be responsible for increased number of households. Can these changes result in any unexpected spillover effects? At the public health facility level, which is the implementing agency, public health facility workers are now occupied with training CDDs and also distributing malaria drugs. Could these lead to any decrease in quality? For the purpose of this short presentation, I'll be presenting on the results for the second channel. So at the community level, CDDs may direct resources away from child health-related services toward malaria-related services. I provide suggestive evidence for this by comparing activities performed by CDDs before and after the intervention. This figure shows the health services provided by CDDs at baseline and at late endline. The light blue bars show the activities performed by CDDs at baseline, and the dark blue bar shows the activities performed by CDDs at endlines. As you can see from this figure, at baseline, CDDs used to provide postnatal care and newborn care and antenatal care. But at the endline, they're less likely to perform these activities, but instead they are more likely to provide treatment for malaria. The second changes at community level that could happen is that since CDDs are responsible for increased number of households, there could be lower access to CDDs, especially for poor households. The CDD interventions, for the CDD intervention, there was a fixed number of CDDs trained per ward, which is 30 CDDs per ward, which means that for larger wards, each CDD will be responsible for higher number of households, which can mean larger crowding out effects for these wards. I checked for this by checking the increase in stunting rate by population quartile. And as you can see from this figure, the increase in stunting is only apparent for larger wards. When I use the interaction term instead, I find consistent results. So to conclude my presentation, I find negative spillover effects of a community-based health intervention on outcomes not directly targeted by the intervention. I find suggestive evidence that crowding out is one of the underlying mechanisms. CDDs direct resources away from general health-related services. Also, poor households are more likely to crowd it out. This study provides policy implications, especially on the debate between the vertical versus horizontal approaches to health programs. While vertical approaches to health program target a selected number of health problems, horizontal approaches to health programs try to address all the underlying health issues in the population. While vertical programs are preferred by donor agencies since they are easier to manage, I find that they might incur unexpected spillover effects on other health outcomes. This is the end of my presentation. Thank you.
Great. Thanks a lot, Michelle. I would now like to invite Anne, who's going to talk to us about targeted instruction and management in schools in Ghana. So Anne, please, can you put up your slides? And for our participants, if you have any questions for Michelle, please do post them in the Q&A chat box. Thank you.
Sorry, Anne, you're on mute.
Thank you so much, everybody. I am so thankful to be here today. These are such great presentations. I'm here today to present our paper entitled Improving Public Sector Service Delivery, the Importance of Management. This is joint with Sabrine Begg and Adrian.
We can't see your slides. Would you just reshare them, please?
You know, we practiced this and somehow it is not working. So let me try again. I'm doing what I did before. Please let me know if this is...
They're there now. So
okay.
You're successful.
Okay. Can you see them now?
If you could maximize them. Yeah, that's lovely. Thank you.
Okay, sorry about that, everybody. We did practice. So I'm here today to talk about the importance of managers in the public sector specifically. So we know that managers are important to productivity in both the private and the public sector. Recent work has indicated that management consulting in the private sector can generate large gains for firms. And we know that there's a large body of literature also showing that in the public sector, civil service more generally, healthcare and education specifically, that management practices are correlated with better productivity and better health. And in the case of education, higher test scores and more learning. And I think what a common goal is among developing country governments is to expand the production and productivity of the public sector. There's generally a large body of work on effective interventions and how to improve service delivery. The challenge is often taking those small scale lessons and applying them to the public sector. So what we there's the papers there cited show that when effective programs are implemented by NGOs without an involved PI, oftentimes the effects are zero. So the challenge that we approach in this question is, can engaging the existing civil service managers improve public sector service delivery, specifically in education? So what we do is we partner with the Ghanaian Ministry of Education to test how to improve management and student learning in schools by taking a proven intervention and scaling it up. This is a 3-armed randomized controlled trial. Our 3 arms as follows. The first is to train teachers in an improved pedagogy and provide those managers an observation checklist. The second arm is that we provide those same treatment as in T1, plus we provide additional management support for managers. We do a several day long training I'm going to describe in detail shortly, and we help to improve the management capacity more directly. The third treatment arm is the control group or business as usual. We want to stress in this paper that this was entirely done by and with the Ghanaian Ministry of Education. Everything that is being presented here today was done within the existing system. So different agencies within the ministry designed the materials, distributed them, led and coordinated training, implementation, provided all incentives, remuneration, supervision, etc. This was all done within existing systems. So to preview our results, we show that governments can scale up successfully and improve student learning. So what we find is that even with existing personnel, management quality can increase by a relatively light touch intervention. Specifically, what we find is that teacher training and providing their manager a simple checklist improves substantially standard measures of school management. We find that when you train managers, their management quality can improve even more. We find substantial changes in the actual operations of the classroom. These classrooms are more engaging and interactive, and we find that teachers actually are in the classroom more often. Finally, we find that student test scores increase in both groups by 0.11 standard deviations, which is about a third of a year of learning within 1 year. So these are pretty large effects, but we don't find that the additional management training differentially improves student learning. We make 3 contributions. First, we make a contribution to the literature on management, specifically management in the public sector. Not only do we validate and use other validated measures of public sector service management, we also demonstrate that management can be substantially improved by a relatively light touch intervention. We also show that this sort of management support does seem to be important for scaling up effective programs within systems. We engage managers and have similar effect sizes to an NGO-led efforts. Finally, we show that improving student learning can be done, and that the status quo of low learning across many developing country settings can be changed within the existing systems. More recent literature has demonstrated, for example, outsourcing can also be effective. We demonstrate that this can be done within the existing system. So let me tell you about what we do. What we do is we take differentiated instruction, which has been demonstrated to be effective across several different countries and settings, including learning levels, and we embed it into an existing system, and we engage managers in 2 different ways. So let me just back up and describe to you what we know about differentiating instruction. So differentiating instruction is when you take students and teach them by their learning level instead of by their grade for several hours per day. This can take on a variety of forms across different interventions. So it can, for example, be pull out, where the students are actually, remedial students are actually pulled out of the classroom and given intensive training. It can also be full year tracking, where students are not taught according to their grade at all. It can also take the form of hiring additional teachers to work in the classroom, that is assistant implemented DI there in the middle. And then we also have teacher implemented DI, which is where the teacher does this new pedagogy where they teach according to the learning level instead of their grade level curriculum for several hours per day. And what we know here is that with enhanced supervision, so in the Banerjee et al. Paper, they actually hired another level and added a whole nother supervisory level to their system. We find that effects are about 0.09 standard deviations across these other across that program. However, we notice here in the teacher implemented differentiating instruction arm to the right of my screen, you see that generally when you apply differentiated instruction within the existing supervision without actually engaging those managers, effects are small and statistically are not statistically different than 0. This leads us to thinking that the importance is not only just differentiating instruction, which seems to be effective, but also supervision does seem to be an important component of how to scale these programs. So using these insights, what we did is with our government partners, we implemented the following randomized controlled trial. T1 has DI only with some additional managerial support. So teachers receive DI training and teaching and learning materials corresponding to the program. The teachers then did a baseline leveling exam at the beginning of the school year, and then assigned students in P4 through P6 to various learning levels in English and math. Those were the targeted subjects by the government. This is a part day differentiating instruction. So for 1 hour a day, 4 days a week, for 8 weeks of the term, students were divided by learning level. So, there's generally level 1, 2, 3. There's grades 4, 5, 6. So the students were combined and remixed and separated again according to learning level. Now this is crucial. Their teacher supervisors and then the supervisors of the head teachers were invited to the DI training, taught also how to do it, and also given observation forms to document whether or not teachers were doing it and to ensure that the program is being implemented. Then, as standard with other new programs in the government, the national and district monitors conducted terminally DI monitoring. In addition to that DI only arm, the DI plus management arm included the first treatment plus additional managerial training. So the head teachers and then their supervisors, the circuit supervisors, received management training handbook and reference cards. They received text messages to remind them of various milestones within the DI pedagogy. For example, you should do your leveling exam now, etc. They were grouped into WhatsApp groups to encourage peer-to-peer learning. And there was also a help desk, which turns out wasn't very much used, but it existed to be able to answer questions in a fast manner. The third treatment is the control group. So you'll see that management isn't the management components of both intervention are actually not solely just in the management arm. The management component is the one above it should also be blue. The management component and the supervisory component are actually in both of the treatments. So what do? We collected 4 rounds of data. We have baseline surveys, including student assessments. We did 2 unannounced spot checks where we capture attendance and we do a classroom observation. Then at the end of the school year, we did student surveys and exams. We then tried to go back the following year to do an unannounced spot check, and the original plan was also to do a follow-up. That was disrupted due to the pandemic. We're hoping to go back, but it's all a little bit uncertain as COVID has not, well, we all know. Okay. So the empirical specification is pretty standard. We measured.
Just wanted to jump in and say you have 5 minutes left. Thank
you.
Perfect.
Yeah, perfect. Thanks. So the empirical specification is relatively straightforward. We have the DI arm, the DI plus management arm, and then we examine outcomes, and we also present to you the F test of the whether or not the 2 treatments are different from one another. So here are the results. We first break down and show you that management's meaningfully changed in schools, and we classify our management variables according to the World Management Survey by Lemus and Skur, which has been adapted to the public sector in developing countries. We show that instructional management, meaning management measures that are directly related to instruction, such as teacher observation, teacher feedback, things like that, those sorts of measures of management that directly relate to instruction in the classroom substantially improve in both arms by about 0.4 standard deviations. These are normalized to the mean of the control group. We find that people management, meaning the aspects of management that are more support and human resource and relationship building between a supervisor and their subordinate, those sorts of measures of people management, which have been demonstrated to be important in other contexts, also substantially improve in both arms, but the effect in the DI plus enhanced management arm is about double the size. We find that all other aspects of management, such as performance rewards, holding meetings with parents, these sorts of other management aspects, also substantially improved in the DI plus management arm, as well as the DI only arm as well. We find that as another measure of management, whether or not people show up can be considered a very basic and straightforward measure of management. We show that following the implementation of targeted instruction and differentiated instruction in schools, school was actually more likely to be in session. Classes were actually more likely to be taught by about 3 percentage points in both groups. We find that head teachers are more likely to be present at the school at the start of the school day by about 0.1 to 0.15 percentage points. Now you'll notice that in the control group, about 42% of head teachers are present at the start of the school day. Attendance is relatively low, so this is a pretty meaningful percentage increase. We find no change in teacher attendance, although point estimates are suggestive. And briefly, the classroom was more engaging. Teachers were more likely to be teaching in the classroom by about 11 percentage points to 13 percentage points, and the classroom is more engaging. So previous attempts to implement this sort of thing, even in Ghana, had serious implementation issues. But we find that basically, according to self-reports, nearly all teachers and headmasters report that they implemented the intervention, and unannounced spot checks, about 60% of all schools are implementing DI by an independent observer. So we think the implementation was quite high. And how does that translate to test scores? We find that test scores substantially improved by about 0.1 standard deviations overall, which is the gray bar there is how much students typically learn in a year. So our magnitude of our effect is about 30% of what students typically learn in a year. They did that just a little bit faster with this new pedagogy. The thing, though, you will notice, though, is that that enhanced management did not translate into improved test scores. Instead, it seems to be that differentiating instruction seems to be driving our increases in test scores. So we can also look at non-cognitive outcomes, and there's not many student level results that are significant between the groups or overall. However, one thing that has also been found is that sometimes when increased management is a short-term outcome, and then once the management consulting or the additional training is removed, then the managers no longer implement that given training. We find here that actually there's substantial persistence. So in year 2, there was no support due to some issues in the ministry. There was no training and no materials provided during the follow-up school year, but yet we see that even without any support, our management changes lasted. We see that
just to say your time's up, so if you could just wrap up in the next minute or so, that would be great. Thank you.
So basically, we find that teacher retention is substantially improved in the DI plus management arm. So to summarize, we find that training teachers and their supervisors substantially improved education, all within existing systems. Thank you so much.
Great. Thanks a lot, Michelle. We'll now move to our final presentation. Can I please call Yasir to speak about mission motivation for health workers in Pakistan? Yasir, can you please put up slides? And again, for people who have questions for Anne, the Q&A box is open. Thank you.
Hi, everyone. I hope you can hear me and see my slides. My name is Muhammad Yasir Khan. I'll be presenting my job market paper, which is basically asks the question whether public sector organizations can strengthen the mission motivation of their workforce and whether that translates into better performance by the workers. So basically, the study is motivated by this challenge that almost all organizations, but specifically public sector organizations in low-income countries face, which is to get their workers to exert effort on the job. And this generally, we like to think we think that if an organization is faced with the challenge of getting their workers to perform, then the first thing that comes to mind is that of providing them some sort of incentives to get them to work. However, providing incentives in public sector organizations is not always feasible for a number of reasons, but two that have been discussed a lot in the literature are, one, many public sector workers are required to perform multiple tasks. Michelle's presentation that you saw was kind of a very good example of the multitasking problem of incentives in the public sector, because if you incentivize workers on some tasks, then seminal work of Armstrong and Milgram suggests that basically workers are going to exert effort on those tasks, and most likely at the expense of other non-incentivized tasks. The second, even if there is no multitasking problem, many studies have shown that when you provide incentives for pro-social types of tasks, there is a high chance that the intrinsic motivation of workers to perform those tasks actually can get crowded out. So because of these limitations, then it becomes kind of important to understand what else can the public sector organizations do to get their workers motivated. And one such strategy that's available to them is that of the mission motivation of workers. Several people in literature have argued that mission motivation is actually very important for public sector employees, because it helps attract public sector organizations attract particular type of employees to work for the public sector. But largely this literature kind of assumes that the role of mission is only important at the selection margin, and the literature is silent on what happens conditional on selection, whether this mission motivation still continues to play a role, whether organizations can improve the mission motivation of workers or not. But anecdotally, when we look at the world around us, it seems like many organizations invest in strategies that continue to remind the workers about the organizational mission with the view or with the hope that it will strengthen their mission motivation. And there are also anecdotal evidence that workers actually care about what the employers communicate to them. So then the question is that if workers really care about what the employers communicate to them about the role of mission in this organization, this can turn out to be a cost-effective strategy to actually get workers to improve their performance without the need of providing additional financial resources. And this is something that I try to investigate in my paper by asking this question: whether public sector organizations can get their employees to exert costly effort on their job by emphasizing the organizational mission to them instead of giving them financial incentives. And I studied this question through a randomized controlled trial in Pakistan by working in partnership with the Department of Health in the Haripur district. And in this experiment, I focus on the community health workers. These are the workers who are responsible for providing preventive and basic health care to rural communities in Pakistan. And you've seen examples of these in previous two presentations as well. But one thing that sets the Pakistani context slightly different from other countries is that the community health workers are really the backbone of the public health service system in the country. There are about 130,000 such workers in Pakistan. It's an all-women workforce. There are no men involved as such in being a community health worker. The workers are importantly loosely attached to a facility, but they work independently in rural communities, and there is no geographical overlap between their areas of responsibility. In my context, in Haripur district, they're responsible for serving about 156 households on average. As I mentioned, these are basically outreach workers. Their basic job is to provide preventive and basic healthcare to their communities. And while performing this job, they perform multiple tasks. And I divide these tasks in something which you can think of as core duties. These duties are part of their job description. And these include that they have to make home visits to every household in their community every month. If the household has a pregnant woman, they have to provide antenatal checks. They have to keep track of the children, the health of the children in the household, and provide basic health literacy to the families in the households. Now, in addition to these core duties, the department asks them from time to time to perform these additional tasks, which is something similar to what you saw in Michelle's presentation. And I focus on two such additional duties. One is the tuberculosis screening. So the department actually has asked these workers to screen households for the potential existence of tuberculosis cases, and then recommend them to visit to seek proper treatment. And the second is organizing immunization camps in their community in partnership with other health workers who are trained to actually inoculate and immunize children in the community. These workers are full-time public sector employees. They receive a fixed salary of rupees 17,500 a month. But in their jobs, there's no incentive to grow. There's no career incentive. So there's no definite or open pathway for them to move ahead in their career. They are hired as community health workers, and most likely they retire as community health workers. So I'll now provide you some detail of the experiment. As I mentioned, I did an experiment in one district of Haripur in Pakistan, and in there I randomized community health workers in 5 treatment conditions, and I'm going to describe the main treatments and give you a summary of what I did just now. So the main treatment that I did, remember my question was, can public sector organizations get their workers to exert costly effort on the job by emphasizing the role of mission to them? And the way I did it was I organized something which I called the mission sessions for the workers. Basically, before the start of the experiment, we went and recorded a video of the senior manager of the Department of Health discussing and describing the organizational mission to these workers. Then the department invited workers, the randomly selected workers, to this mission session, where we showed them this video of the senior manager describing and emphasizing the organizational mission, which is then followed by an open discussion about the role of mission in the organization. So we have a facilitator at hand who actually facilitates these meetings. They open the floor to discussion. They ask the workers to share their thoughts, their beliefs, their experiences about the organizational mission, what they think about it, what they thought the organizational mission was, whether they had actually thought about linking the link between their day-to-day activities and the organizational mission. And so basically the whole idea is we have this participatory session in which we make sure that the workers participate and kind of internalize that organizational mission is kind of an important thing for the Department of Health. After this discussion, we also have a short skills refresher training for these workers, which focuses on skills, basic skills required to provide services for mother and child health. This is also done in a case study kind of a manner, so everything is very participatory. The facilitator asks questions and people respond and to the facilitators. The skills refresher training is important for 2 reasons. One, it basically gives us a context for the mission treatment, and then also enables me to have a placebo treatment that I can use to study certain alternative explanations. And also it makes sure that the mission treatment does not look out of place, and it basically the workers see it as kind of an organic activity that is happening in the department. Now, I want to point out that these are not a one-time sessions. We have 3 monthly sessions during the experiment. So every month they meet for 3 to 4 hours, discuss the organizational mission, share their thoughts, share their experiences, and then participate in this skills refresher training program. And this goes on for 3 consecutive months.
Yasir, just to point out that you have 5 minutes left.
Oh,
Thank you.
okay. Okay, let me speed up a little. The second treatment is basically, I also want to see how the mission intervention actually performs to more traditional financial incentives. So the department actually tells them that they can earn a little extra money every month if they visit more households in their community, and they are offered up to a reward of up to 500 rupees a month, which translates into about 2.9% of their monthly salary. Then my third main treatment is basically combination of the mission sessions and financial incentives. I want to see how the two basically interact with each other and whether there is any crowding out that happens. A fourth treatment condition is the placebo, where the workers actually meet and they receive skills refresher training program, but there is no discussion of the organizational mission. And this placebo mimics the mission treatment without any discussion of the mission. And fourth is basically pure control, business as usual. I work with 710 community health workers, and I do an individual randomization of workers in 5 treatment conditions, but the randomization is blocked at the mother facility level. For data, I send my own survey teams to survey households in these communities. For 3 consecutive months, we collect information from 7,100 households on a very simple survey tracking whether the workers are visiting them households or not. And we also have an additional round which we do after the experiment has ended. And I supplement this data with worker survey and some administrative data. The estimation strategy is pretty straightforward. I control for each treatment condition with a dummy, and I also include randomization block and survey month fixed effects. Whatever results I show, the left out category is always the pure control group. So let me show you first whether the mission treatment actually led to an increase in the home visits, because that's what the first step of performance of these of these workers. I'm going to show the results graphically. So I'm going to plot the coefficients on this graph. On the y-axis is the effect on the probability of a household visit, and on the x-axis is the treatment conditions. Before I show you the results, the thing to note here is that the control mean is 0.35, which means that they visit about 35% of the households in the status quo, which basically tells you that's a low performing environment. First, the workers who participated in the mission sessions, they improved their performance by about 5.7 percentage points, which translates into about 10 additional household visits that they make every month. We can be confident that this is a direct effect of the mission treatment, because when you look at the placebo treatment, which mimicked the mission treatment without any discussion of the mission, we do not see any significant improvement. In contrast, the financial incentives actually improved visits by a lot. Remember, they are getting paid for visiting more households. So not surprisingly, that led to an improvement in the household visits. When you look at the treatment condition which combined the mission and the financial incentives, that also led to an improvement in household visits. But if you look at the gray bar and compare it with the blue bar, as you can see that the effect is actually smaller than the financial incentives alone. Remember, they both types of workers are getting the same financial incentives, but it appears that workers in the combined treatment are leaving money on the table, and the combining mission with financial incentives actually making financial incentives less effective. But this is only on the incentivized tasks. And I collected information on what they do on the non-incentivized tasks. Non-incentivized tasks such as antenatal, do they perform antenatal checks? Do they keep track of children's health? Do they discuss disease prevention? Are they screening households for tuberculosis? Are they organizing immunization camps? I collect all this information and combine in an index which I call the non-incentivized task index. So the next results that I want to show you is whether there is any change in the performance of workers on these non-incentivized tasks. And what I find is that the mission treatment also improves performance on the non-incentivized tasks as well. And this improvement, it achieves about improvement of about 0.16 standard deviations. Whereas the workers who participated in the financial incentives group actually do not improve performance on these non-incentivized tasks. And because they are not getting any financial incentives to work harder. There is no negative effect. So there is no crowding out as such on the non-incentivized tasks, but there's no positive effect either. However, the workers that participate in the mission session and also receive financial incentives also improve their performance on the non-incentivized tasks. So remember, these workers actually were also improved performance on visiting more households, but that improvement was less than the financial incentives. But here they are improving on performing these non-incentivized tasks.
Yasir, your time's
Yeah.
up. So just wanted to say if you could wrap up in a
Sure.
minute or so, that would be excellent. Thank you.
Sure. So basically, what is happening is that the workers, when they are given financial incentives and also provided participate in the mission sessions, they become motivated to become better workers. And that means that they optimize by allocating effort to all types of tasks, which leads them less amount of or smaller space to improve performance on the incentivized tasks alone. Now, I also find that these changes in the behavior of workers led to an improvement in the health outcomes of the community. The mission treatment achieved a higher improvement in the health outcomes. In terms of mechanisms, I argue that the main channel through which the mission actually gets these changes in the behavior of workers is that it makes the workers more intrinsically motivated. And I find I have three pieces of evidence to support that. I find that the workers' stated beliefs is such that it indicates that their own preferences are aligned with the organizational mission now. I also find that even the effect of the intervention persists even after the experiment has ended, which suggests that the workers were really motivated to perform better, which meant that even when they didn't have any mission sessions, they still continued to perform better. And this improved intrinsic motivation can be detected in a lab setting even 1 year after the experiment has ended. Additionally, I do not find any evidence that the perception of being monitored plays any role in getting workers to exert effort. And I do not find any additional support for peer influence channel, or to think that the workers are performing better because they think that they may have some social image concerns. So to wrap up, basically what I find is that mission is actually a powerful motivator compared to financial incentives for public sector employees working in a health service delivery. It helps, mission can actually help organizations improve performance of workers, not just on the headline tasks, which are easy to measure and contract on, but also on multiple tasks which are difficult to incentivize. And it also then leads to better health outcomes of the in the community as well. This is a specifically important tool for low-income settings because mission actually comes as a cost-effective strategy. And thinking about the world around us as we move towards vaccine distribution in low-income countries where resources are limited and vaccine supply is going to be limited, it raises an important point for policymakers to think deeply about how they want to incentivize workers to ensure that the distribution of COVID vaccine is not only swift, but also more equitable and does not get distorted in any way. Thank you very much for your attention.
This was really, really interesting. And I think what might have stood out for our audiences is how deeply interrelated each of these pieces were in one way or the other. And for me, I think two things that really stood out were how do we think about public sector jobs that are multidimensional, where we know agents are carrying out many, many different types of tasks, and what happens when vertical programs or even incentives tend to just focus on one outcome, and what kind of unintended consequences might that have, or how that might affect other outcomes that are not directly incentivized. And I think another key thing that stood out for me was that how do we think about middle management? And this is not only from the perspective of thinking about how they might improve implementation, which is what Anne showed, but also the very important issue that Yasir spoke about, where how middle management can actually be used to emphasize mission of organizations. So I think for me, those are two key messages, and I'll be walking away with that and thinking about how we need to think about service delivery differently in light of these. And with that, let's just go to our very exciting Q&A session now. Now, can we please go to Martin Williams, who had a question for Michelle?
Thanks, Zahra, and thanks to all the panelists. I thought these were 4 really, really interesting papers and really great presentations all around, so thank you. So for Michelle, I really loved the focus on this paper and trying to sort of measure the unintended outcomes and in terms of effort shifting of these workers. And I found it interesting that there was clearly such a strong realignment of kind of time and effort based just on one training. And so I was curious, to what extent do you think that the impact of this was purely because of the training itself, or was there also a kind of shift in emphasis or prioritization, either explicitly or implicitly, from kind of the supervisors of the health workers that you were looking at?
Great, thank you, Martin, for your question. And now Jennifer had a question for Anne. So if we can just take that, please.
Yes, thank you, Zahra. Thank you, Anne, for your presentation. It was really interesting. I have a little bit of a background in targeted instruction, so I had wanted to find out my little knowledge of what happened in Ghana. There was a lot of issues with implementation, so I'm glad you spoke about the implementation aspect. And just wanted to know if maybe there would have been an even more of an increased effect of the mentorship or the management aspect if there was an intensified training for these managers, quote unquote managers, but I don't know how long they were in training for. So I just wanted to have an understanding if they attended maybe one day of training so they were sensitized on what was happening, or they actually attended the full training that all the implementing teachers also attended. I found that quite interesting, and also just understanding how the assessments worked, if the students were assessed baseline and just end line, or there was some kind of re-leveling as students were learning, and how managers or head teachers were involved in that process. Thank you.
Great, thank you, Jen. And now can I please call upon Kenneth to ask his question to Yasir? And can I also request all individuals asking questions to please keep it to one question per person. Thank you.
Thank you. So I had a question about the use of the term intrinsic motivation. I was very, I enjoyed the talk. I'm very interested in reading the paper. But when you talk about intrinsic motivation, technically that means motivation that comes from within. And then you discuss this program, which is altering people's intrinsic motivation through messaging. And so I encourage you to be much more explicit about what you mean by intrinsic motivation, and maybe to think more generally about pro-social preferences and how they're interacting with these community health workers. I'm sorry, it's more of a comment than it is of a question, but anyway, I'm a little concerned about the technical term intrinsic motivation means motivation that comes from within, and therefore shouldn't be very easy to alter from the outside. But I very much enjoyed your paper. Thank you.
Great. Thanks, Kenneth, for that really useful comment. Can we now please go back to our speakers, and if you could respond to these questions, and then we'll come back for another round of Q&A and discussion. Thanks.
And I agree with you that this large shift in activities happened not just because of trainings, but because of the new assigned role as a community-directed distributors. Actually, this role was invented by this program. They were previously community health workers, but now they are called community-directed distributors, and they can distribute free malaria drugs and also diagnose people with fever with RDT kit, rapid diagnostic kit. So it's because of this newly assigned role, I think, that this large shift happened. Thanks.
Great, thank you. And can we now move to Anne, please?
Mm-hmm. Hi. Thank you so much, Jen, for that question. So yeah, actually, one of my co-authors was part of the team that evaluated, it's called TCAI, which was also in Ghana. And based upon those results, the ministry wanted to go forward with our project STARS. Demonstrated promise with learning, but there were implementation issues. And so this is kind of an iterative, I didn't present the background, but this is kind of an iterative a movement by the ministry to continually improve and based upon what's worked in the past. So the training that we provided, not me. The government provided to the managers was about a 3-day management program with a refresher midway through the year. It was all day and run by, in a train the trainers model, run at the district level. The assessments, so it was relatively intensive, but it was nowhere near, for example, a management consulting. You know, it's what somebody could do short of telling them to go get MBAs. You know, we have to work within the system. So as far as the assessments worked, we were very careful to make sure that we assess students not based upon the leveling exams or questions that they had seen before. It was very important to us to make this a objective evaluation, and for example, not give students who had seen the questions before a leg up. We were very careful to that. We do an adaptive test and use item response theory in order to evaluate our tests. We validated it extensively with piloting as well to make sure it was at the right level. And that's how the assessments worked. Within the schools, the teachers nearly all report that they did the leveling exam, similar to our results on implementation. In our model of differential instruction, they were instructed to re-level the students every every term. And I need to look at that offhand. One thing that I didn't present to you is that the teachers, the head teachers in the enhanced management arm actually were more likely to validate that the teachers had allocated the students according to their proper learning levels. They were significantly more likely to have done that step of the process, but generally point estimates are such that there's generally not much difference. There are some knowledge differences on how the program is supposed to run by management, by the management training, but it's a pretty small magnitude in general. So we think that as far as getting the ball rolling and getting them to implement it at all, we were very pleased that with this additional light touch training, we had a 4 or 5-fold increase over what the previous iteration of this project had been able to do. Thank you.
Great. Thanks for this really comprehensive answer. And I'm sure Jen can take it with you offline as well if she has more questions. Can we now move to Yasir? Yasir, would you like to offer a comment to Kenneth's comment?
Thank you very much for this comment, actually. I mean, this is, you are very right, I should be careful. The problem is that with intrinsic motivation comes from inside, but what I am measuring, it's basically their motivation for their job. Now, the problem arises that it is basically getting activated because of an extrinsic kind of a stimulus. So I take your comment. I just want to also point out that there are, the literature is such that there are kind of possibilities in where we can kind of extend the definition of the intrinsic motivation, but I take your comment. Yeah.
Great. Thanks, Yasir. And this is an ongoing discussion, I think, especially as economists, when we're trying to understand how to model and think about intrinsic motivation. This is a challenge that we've all been confronting, but that was a really useful comment. So thanks for that. Can we now please go to Victor? Victor, you had 2 questions, but you had one for Michelle. Could you please ask that? Thanks.
Yes, thank you so much, Michelle. So just a question on the overall effect of the program. So you mentioned some positive effect of the program on malaria. And could you maybe elaborate a bit on how this positive effect compared to the negative spillover effect you find? And overall, would you say that the program still had a positive effect? Thank you so much.
Thank you for your question, Victor. We haven't actually calculated the overall effect, which I should do after discussing with my co-authors. But for the main paper on the impact of the prevalent malaria control program, we find a positive impact on malaria reduction only when the quality of primary health facility is above median in that ward, which means that the main policy implication from that paper as well was that informal health providers should be regarded as complementary with instead of substituting the public health system, which I think is also in line with this paper. I'll make sure I'll calculate the overall impact and have something to say about that. Thank you.
Great, thanks, Michelle. And I believe Martin Williams had another question for Anne.
Yeah, just really quickly, Anne. So again, I absolutely loved this paper, and something that I missed or was a little bit confused about was in terms of the impacts on management. To what extent were the changes that you observed sort of associated with the management of this specific program versus sort of management of the school more generally? So kind of did you, whereas Michelle got these kind of negative spillovers, did you get positive spillovers to non-targeted areas of management?
Anne, would you like to take the question right away? Thanks.
Yeah, thank you so much. Sorry I didn't get a chance in the brief presentation to outline this. That was our motivation actually for dividing up our measures of management into the 3 types of categories. So we have instructional management, which is basically very closely related to teaching and specifically the aspects of management that are related to the program. Then we divide up into personnel management, which was emphasized specifically in the training, which isn't related to necessarily differentiating instruction as a program, but it was what we taught them to do. I keep saying what they were taught to do. And then we also break it down into all other aspects of management. And so we sort of try to get at that. And what we show is that aspects of management that are directly salient to differentiate instruction improve symmetrically. Aspects of management that we taught them improve differentially, and overall management also improves differentially. So it's an overall improvement in management that that there are spillovers onto other aspects of management. The puzzling part that we're still trying to work out is we generally think management matters in schools. So why didn't that additional management improvement differentially improve test scores? We're still working on trying to answer that, but it should be thought of as a general improvement in management capacity, potentially through role model effects. The head teacher was actually showing up in the class, in the school more often. Thank you.
Cool, thank you.
So we're almost reaching the end. We have a couple of minutes left. So I just wanted to put out a question to our speakers. If you were to give policymakers one message of how to improve frontline public service delivery, what would it be? This is not to put you on the spot, so just kind of, we just love to hear more from you as to what would be that one advice that you would give, and also a message that our participants should walk away with today. Thanks.
So my main finding, I think when designing a development program, especially a vertical approach to health programs, I think it's important to also think about the unintended spillover effects that can happen.
Great, thanks. Anne?
My approach would be that differentiated instruction is very effective and can be effectively scaled within the government systems. It does not, governments do not need to outsource expertise to the private sector, for example. But it does need support and management, improved management capacity, which can be done with even a light touch intervention. Thanks.
Great, thanks. And Yasir.
So my recommendation would be to think holistically about organizational and incentives design, basically not just rely on financial incentives, but also act on the mission motivation of workers and think about holistically the job environment of the workers, especially keep in mind the multitasking nature of the public sector jobs.
Excellent. Well, we'll all walk away with these very useful recommendations. Thank you to everyone for joining this session today. And don't forget to tune in for our next session, which is at 2 p.m. Research Frontiers in Health and Education with Martin Williams. Thanks once again for joining us.